Hear you now.
Okay.
Good. So could you go ahead and explain what BPPV is so
Yeah.
everyone can understand?
So what Jeremy was saying was BPPV is benign paroxysmal positional vertigo. And a lot of people, I'll first define the definition of vertigo. Vertigo is people come into the clinic and say, oh, I have vertigo, but they actually don't have vertigo. They might have some dizziness or whatnot. But vertigo is that kind of false sensation that you're actually spinning. And there's that kind of rotational component to it. So true vertigo will be like the room is kind of spinning around me. Benign, meaning that it is non-life threatening. So, a lot of people that come to the clinic, they have that first episode of vertigo and they think something's really, really wrong with them. And they're not feeling very well and, and they're scared. But benign meaning that it's not life threatening. So it's something that's curable. And we'll talk a little bit more about the treatment and how we can go through that kind of stuff. And then paroxysmal means that it's very brief. It's a brief kind of episode of it. So usually it doesn't last more than a minute long, the episode. So it'll just pass by. And then you can have an episode during the day and you kind of go on with the rest of your day feeling pretty normal. Positional meaning that it's usually affected by some change in position. So a lot of patients come in, they'll come and say, I was lying in bed and I got up and then I felt like the whole room was kind of spinning. So it's kind of related to a positional conduct. And then the vertigo part is the whole spinning area there. So that's what we're talking about today, BPPV. It's the most common form of vertigo. And so I'll go in a little bit, Jeremy will go a little bit more in the anatomy a little bit later on, but I'll kind of talk to you about, a little close note of what happens. So inner ear is, there's these three canals and they have fluid inside them. And their job is to kind of tell us how our body is moving. So if I'm turning my head to the left, the fluid kind of shifts in the canals and tells my brain, hey, Alan, you're moving your head to the left. If I'm looking down, same thing, the fluid kind of shifts and it tells my brain, hey, Alan, you're looking down. So it's a very important tool that we have in our head, in our ear, that we have to use to help us where our position of our head is. What happens sometimes is these crystals, they get broken in and it gets dislodged into these canals. And so now if enough of these crystals kind of accumulate, then they'll make us feel like we're moving when we're not really moving. So when I'm standing still, and say I'm lying down, I get up and I'm sitting still, the crystals continue to move the fluid, and then it makes me feel like I'm spinning around. When my eyes are telling me that, hey, you're not moving, the muscles in my neck and my spine are telling me that I'm not moving. The good ear is telling me that I'm not moving. So that mismatch of information causes, that kind of spinning rotational feeling. And so that's really the kind of like the close notes of how it works. And Jeremy will go a little bit more the anatomy a little bit later on. And then the other thing too is we talked about this being paroxysmal. So it doesn't last, typically doesn't last very long. So, if you have an onset of this and it's constantly there, then that might be something else. And that might be something you talk to your doctor about. Any other symptoms that kind of come with it, BPPV doesn't cause uncoordinated movement or, your ability not to be able to talk. Any neurological symptoms that come with it, that's something more along the lines of going to the doctors and talking about it. But yeah, that's BPPV. And people typically say if the room is spinning, they feel like it's kind of spinning around. They might feel nausea, vomiting, and maybe a little bit of disequilibrium and feeling off balance. But those are the basic symptoms. And yeah, so that's basically what we're going to be talking about today.
Awesome. Thanks, Alan. Just so everyone knows, when we talk about spinning and we talk about vertigo, people are like, well, what does that mean? If you haven't experienced it or you don't know someone close who has, we've all grown up and as kids, we tried to stand in one spot, turn in a circle and do this as fast as we can, right? You do it like 10 times. And that feeling once you finish where you fall to the ground, that's a sensation of vertigo where there's spinning and it's out of control. And that's because your inner ear was firing so much and your brain isn't used to it. And that's exactly the feeling. That's why some people who have an acute episode can look up in the air and just fall down because they're so out of balance. So I'm going to take what Alan said and just break down a little bit more anatomy because I know what he said was pretty heavy. There's no doubt. I mean, that was the same way I felt in physio school. Can you guys see my screen there? Just nod if you can. Okay. So Alan was saying in the inner ear. So if you guys, hold on a sec, you guys see this little apparatus here. And I got a 3-dimensional device that I'll show you in a sec, but it's in the inner ear. So we have this portion right here. That's the cochlea. That's our hearing device, not related to the inner ear that we're talking about right now. What we're talking about is these semicircular canals right here. You guys see how there's one loop, 2 loops, 3 loops? Each loop is in a different orientation, so that if I were to turn my head this way, that way, it activates a different canal, okay? And then we got another area here, and that's like the vestibular apparatus where the utricle and the saccule are. That piece of anatomy or anatomical structure is for if I were to move forward, backwards, side to side, or up and down an elevator. So one is linear motions, the other one is rotational ones, okay? And then you see here, there's a nerve, and that's gonna go and be connected to the eyes. And there's an inner ear on the other side, also connected to the eyes, to tell you where you are in space. So to break down the anatomy just a little bit further, again, the cochlea is here. Like I said, the utricle, saccule, those calcium deposits live in here. And their function, like I said, is to help us with forward, back, up, down. But once in a while, because of different factors, it could be a concussion, it could be an infection, it could be inflammation, a whole bunch of things. These will get dislodged and go hang out in the point that's more gravity dependent. So it's going to go obviously and sit right here. And so right here, now you have anatomy that was supposed to be in here. It's now over here. So what we need to do is find a way as vestibular therapists to chase it back home right here. Okay, so hopefully you guys can put that together. Now I'm going to try and explain, I'll get rid of the screen here. I'll try and explain to you guys how you guys can see this is the inner ear blown up. It's obviously not this big. You see there's semicircular canals. The crystals live in here. It would be localized right in here. So this is connected to my eyes. So if I'm going to turn my head to the right, the fluid in these canals is going to move and send a signal to my eyes to say, you want to look at every person on the screen. I can see every one of you, even though your videos are off. But if I turn my head to the right, notice how I'm not losing focus of it's a reflex, and it's the fastest reflex in our body. If I go this way, super easy. I can look at you. It doesn't matter where I am. My fluid that's moving around is telling me where the camera is, right? So if you have crystals that get dislodged and they go into this canal, we'll say it's represented by that ring here. You guys see that? This is crystals that are not supposed to be there. Obviously, it's within this tube. So it makes it fire more because those crystals, they brush up against these little hair cells and make the signal happen faster. So it's stimulated. So now you're just sitting here, you turn your head, the signal that's sent to your eyes is way more intense than it's supposed to be. So then your eyes start to bounce around in your head when you start moving these canals around because the crystals are adding more friction within that semicircular canal, right? So what ends up happening is you turn, and then because my eyes are naturally supposed to be pushed to the left, they're being pushed to the left too much, then your brain is trying to fix it, then your eyes start to bounce within your head. I know that's a tough one to follow, but that's basically, I'm just trying to teach you guys what should take about maybe 3 hours in 7 minutes. So if you got even a little bit of that, give yourself a round of applause. So the next thing I want to show you guys is just a brief case that I had. This was my very first one. I need you guys to pay like special attention to the eyes of this lady who let me post this. So let me just pull this up. So she had some crystals in her inner ear on the left. You guys have to focus in on her eyes at about 10 seconds. You'll see what I'm talking about, that weird quick bouncing motion happening. And then when the eyes bounce, it feels like that feeling like you're a kid and you turned around a bunch of times and so it's a pretty intense feeling. This is my very first one.
And get her eyes.
So not yet. 3, 2, 1.
There it is.
And then you guys see that little bounce there?
See that? So it's beating up towards the left ear. And it's gone.
So I did something called an Epley's maneuver right after that.
I'm going to move around, and I'm going to move your head. Okay?
So this is about 5 minutes later. I did a maneuver that I'm about to show you guys, but just so you can see the after result. It can sometimes take as little as 5 minutes to treat.
Let's see if it's gone. Or see if we have to do this again. How do you feel? Okay. Camera can't lie.
So there it is. So that just took it. That was a successful case. It only took a few minutes. Now, what we did was a maneuver called the Epley's maneuver. So if you guys can see, like her crystals were right here in this ring. They were here. They fell into here. So what happened is she's here, and all we're doing is we're using gravity to chase this back home right here. And depending on what canal it is, and Alex might elaborate on that in a second, you need to, because like it could be this canal, that one, it could be one on the other side. Based on where the eyes are moving, I knew that it was in this one right here. That's where it gets a little bit complicated. So what the position looks like is I drop her onto her side with her head down. You just see it like it already went from here to here. And then we wait 30 seconds for all the crystals to come here. And they flipped her the other way. And then it comes down just a little bit more. And then I have her look to the ground. You see how the ring continues to move? And I tuck her chin in too, and that gives a little extra. And then once she sits up, the ring is now here, and then it goes back in, and your symptoms are gone. So you just got to know what canal's it in, on what side, and then you could do an appropriate maneuver to fix the issue. Alex, can I get you to elaborate a little bit more on either differential diagnoses and a few other things?
Right. So there are usually one canal that's predominantly affected, probably about 90% of the time, and that's usually the treatment that we do. As there's more awareness, I would say, though, that I'm getting more and more complex cases where people's doctors have tried to correct it or it hasn't worked, and you're getting situations where there is basically the crystals going into different canals. So not the usual common posterior, but also the horizontal canal or the anterior canal. And these require different maneuvers. And there's actually about 9 different maneuvers that we have to select from, depending on what kind of condition it is. There's also a particular condition, as like when we classify it as physiotherapists, if there's just free floating crystals, as Jeremy was showing you, we call that canalithiasis. But there is a particular condition called cupulolithiasis where that crystal can actually adhere to the hair cell. And this gets very tricky because you actually have to now dislodge the crystal from the hair cell in order to then free it up, because you basically have to move it around the circle. If it's stuck to the hair cell, it's not going anywhere no matter how many good maneuvers you do. So what we do in that situation is we do what we call liberatory maneuvers or freeing maneuvers, where they tend to be a little bit more brisk. They can be a little bit jarring, a little bit jolting, or we have to use some sort of vibration, such as a tuning fork behind the ear or some tapping, and that will allow us to dislodge these crystals. And so what goes into our assessment is really dependent on what we see on the eye maneuvers. So when we do these provocative maneuvers, bringing the head back with the person back, we're really looking at the eyes and checking it out. And you, like I mentioned this in the chat there, just so everyone, like I didn't see too much eye movement, but that was only because I think there's a lag on the internet. And so there was like, you couldn't see it quite as well, but normally you see it like really, really vividly. So yeah, that would be kind of the range of treatments that we would go through in terms of assessing it if it is BPPV. I also had a quick fact that I wanted to ask everybody. If they had any idea of when this was first described or found. A lot of my clients, they're asking me questions like, oh, wow, this seems like some voodoo magic stuff you guys are talking about. But really, it's been around for quite a while. So if anyone has a guess, I'll let them throw that out in the chat. Otherwise, I'll just give you guys the answer. Okay, 5 seconds.
There's got to be someone in the crowd who's like that person in school was in front of the class who would answer that question right away. I want that person to step up right now.
Question was, when was it first discovered? BPV, the condition.
Man, I don't even know the answer.
If you have fast Wikipedia fingers, you'll know.
Alex, I would write in the chat box if I knew the answer.
I
Okay.
want to win this, right?
So it is, yeah, it's basically 100 years ago. You got that right, Anne. Okay, good job. So that's when it was first discovered. And then in 1952, so 1921, in 1952, Dix and Hallpike, who created the Dix-Hallpike maneuver, was basically the provocative positioning maneuvers that you could do to basically diagnose this properly. And what they would notice is this fast beating of the eye movement and the patient's reproduction of symptoms. So that's where it all came from. But this isn't something that's all of a sudden, we just figured out. This has been going on for about 100 years. So it's really nothing new. I just think the education of people who can do the maneuver, so doctors and physiotherapists and chiropractors, we're all getting better education and better able to diagnose it. So that brings us to the basically Alan, myself, and Jeremy. We all took a really intensive course in Atlanta at Emory University. And it was a 6 days of lectures and labs where we basically practiced the skills from 8 in the morning till 5 at night. They gave us a 500-page manual to work through. We did hours of video study where all we would do is just look at eye movements on videos and basically be able to diagnose just from the video and knowing what provocative maneuver was done. We would learn about what techniques to use in order to help those patients. We also did skill testing every night, and we did 4 hours of examination toward the end. And if you did a good enough job, they would give you a nice certificate like this, which I was really proud of because that exam was intense. I think the weekend courses that are offered here in Canada are great. They do elaborate on a lot of things, but I think what differentiates us is just the intensity of the study that we had to go through, and really, really, really focus on all the skill testing. So I think that's why there's like a 2 or 3 year waiting list to get into that course, and why people from all over the world are currently trying to get in and taking it.
Yeah, it took me 2.5 years to get into that course.
Yeah.
And keep in mind, guys, if you guys have an episode of dizziness, totally like go see your doctor and rule out your red flags. But don't expect that you're going to get maybe the answer you were looking for. I've been talking to physicians in the Mississauga area now for about 8 months. I probably met with about 75 of them, having discussions about things like concussion and vestibular rehab. And you know what their knowledge of this kind of stuff is? It's about equivalent to me 2 years ago. So you guys might be a little bit more informed on some of this stuff than some of your family docs. So, but their role is to really rule out the red flags, make sure it's not a stroke, a cerebellar stroke, a tumor, any of that stuff. And then some of them will know to pass you along to a vestibular physiotherapist. Some won't. They'll say like, go home and take a medication or whatever. Just keep in mind that there's health professionals that specialize in this. If your physicians don't know, now you guys know. And you can share that with your friends as well.
Okay, so I have a couple more fun facts if you think I should get into that, Jeremy.
Hold on 1 sec. We got questions here.
Sure.
Let's see. We got thoughts. Hold on. The chat's moving on me. My mom's a 91-year-old. It's making me dizzy, to be honest with you guys.
Come vertigo, eh?
Yeah. My mom's 91 years old and has been getting this for years. She's on CERC 3 times daily. We go months with nothing, then just sitting. Yeah. So it sounds like she has BPPV.
Yeah. So
what do? Doesn't matter if she's 91 years old. I can still be delicate with someone. There's no issue. I'm not gonna. Like you guys just saw the maneuver on the video that I showed you. I actually placed her down. A lot of therapists who aren't very experienced with this will go to the head of the table and let people drop themselves down, or they're just kind of brisk. Like the person, it's like you're almost cuddling the person as you bring them down. So 91 years old, 101 years old, I'd still be comfortable doing this stuff with them. So that's good. There was another question up top. Yeah, you can go with your facts, Alan or Alex. I'm 0 for 1 right now.
Okay, gotcha. All right. So the leading cause. This is another question you guys can try to answer. Does anyone have a guess at the leading cause? What causes BPPV?
That's another tough one.
It's a very tough question, almost a trick question. Aging, that's good.
I kind of threw it in.
Yeah.
Dehydration, concussions is right. Dehydration's a stretch, but why not? I think dehydration can cause a bunch of stuff.
Okay, so I'll give you guys the answer. These are some good answers though, for sure. The primary cause, 58%, is idiopathic, so we do not know why. Okay, you could look at aging as a factor that contributes to it because it's more common in age, but as a causative factor, it's not really necessarily a cause. It just has an increased incidence. The second one, whoever said concussions, that's true because with trauma, and it takes quite a bit of force to cause a concussion, 20% will be concussion related. And the other one that was mentioned, I think it was viral was on there. Yeah, virus infection. Alessandro, that was a good one too. This is less common. It's about 8.5%, but those are the top 3 causes.
We got a question. Is there a specific name for the crystals? I know crystals doesn't sound too scientific. It's called technically otoconia or calcium carbonate. I don't know. There's like 3 different words that you could use for it. Otoconia is probably the most commonly scientifically used word for those crystals that get dislodged. And another little thing is just about the eyes, where we can diagnose when we challenge one of these canals by dipping your head back, depending on what turning your head, we're looking at the eyes. So it's like it can go this way, in which case it's telling me it's posterior canal on this side. Your eyes could go this way, which would tell me it's inner ear. It's going to be inner ear middle canal on one of the 2 sides, depending if it's beating up or down, or it can go downwards with a little bit of torsion. So us being able to identify the eyes will tell us, we're looking at the eyes carefully and we're like, okay, it's beating up to the right, left canal on the right or left. So it's basically, that's our diagnosis process. We challenge the canal, observe the eyes. The eyes are going to point what direction, one of the 6 canals, or it's going to tell us if it's free floating in the canal or if it's stuck on the cupula or the hair cells, like Alex was talking about earlier. So there's a lot of variations. That's why this stuff gets super complicated. I remember in physio school, it went right over my head. Like I knew nothing. It was like it was too complicated. Once you have to really dive in and go like the way we did it for 5 days or 6 days and go and learn this stuff, because it is complicated. But I have a pretty good feeling. I know this because I tried to teach this to my mom last night, and she's like, I think she understands BPPV better than I did 2 years ago. All right. You guys see any other questions? The chat box is getting kind of huge here.
Did we ever black out from vertigo? Jeremy, have you ever had anyone black?
No, it's a lot of, if you get that sensation, again, the sensation is very close to if you were to turn 15 times very fast. It's uncontrollable spinning. And then when you stimulate that area of the brainstem, often you're going to get stimulation of the center in the brainstem that causes vomiting. Doesn't mean you're going to die. It's just a side effect, if you will. The sensation that you're going to feel, it's like you're falling off the earth. That's the sensation. But blacking out, no, I haven't seen it.
You, Alan?
Blacking out, no, not blacking out. Had people vomiting and puking in the clinic.
I mean, blacking out is more of like, someone having a little too many drinks on a Saturday night. I don't think you're going to get that with
yeah.
I have one more kind of quick fact. Basically, they've done some studies where they basically ask clients to describe themselves essentially as in terms of which symptoms they feel the most, and there's like a checklist. And I'm just curious if anyone wants to guess what the biggest complaint is. We've given you some descriptions, but you might be surprised at what the actual biggest complaint is amongst people who suffer from BPPV.
And guys, remember, there's obviously we're very zoned in on BPPV today, which I think is 20% of all dizziness. So there's a whole bunch of types. You're going to have a bunch of different descriptors, right?
Hey, we're getting some good answers here. Nausea, that's a good one. Disorientation, loss of control, think it's in the head, insomnia, spinning, anxiety. Those are all good ones. All right, I'll give you guys some of the answers. The most commonly descriptive term was poor balance at 57%. The next one was a sense of rotation, okay? Trouble walking was 48%. Lightheaded was 42%. Nausea, 35%. Feeling queasy, 29%. And spinning inside the head was actually at number 29, 30%.
Nice. It's interesting because as we, if we're just going to be textbook, we assume they're going to come in and it's going to be like, they're going to say it's vertigo, it's like positional, and it's only when I turn my head to the right, and you're like, okay, I can just treat that right away. But it's hard to put words on that feeling. I know it is. Someone asked, red flags, please. So we can touch on red flags, but and I want you guys to know that, but I also want you to know that I want you guys to consult a health professional if you're having this, and not be like, that webinar I saw last year and those red flags, no, they're not mine, so let's just stay put. You know what I mean? And it's like the red flags are not obvious. Like I'd have to do an assessment on someone and check their eyes out and their ocular. There's like a whole variation of a comprehensive exam to rule out red flags. So it's hard to answer that like that. But if someone had a sudden onset of dizziness, or the dizziness isn't going away, or it's not head positional, you want to be careful with that in case it was something like a stroke or whatnot. But it doesn't have to be that. You could have an infection in your inner ear and it's causing consistent dizziness. There's a lot of, and that's obviously more likely than a stroke. It could be a slow onset. So it happens over a course of a month, you get progressively more and more dizzy, which could be the case of like an acoustic neuroma, where you have a tumor growing on the cerebellar pontine angle, which is in your brainstem. So it's putting pressure on that inner ear that I showed you on the diagram earlier. And as it grows, the tumor, it puts a little bit more pressure on the nerve every couple days, and then the dizziness gets worse. I know because I've seen it. So those are some red flags. Like it's a slow onset, but like I don't expect you guys to retain that or memorize it, or even for it to be important for today's talk, because I want you guys to just understand what BPPV is, because a lot of people get dizzy. Everyone has either had it or knows at least one person that has, and that one person or yourself didn't know what to do or where to send them.
So there was a quick question. I would agree with Jeremy about red flags. Always get tested for sure, and more major symptoms, significant symptoms, like numbness on the face, all kinds of stuff like that. That's just weird stuff that doesn't fit. Yeah, you want to get checked out by a doctor first to make sure you're going to the right place. There was a question about CIRC. I'm going to hand that to you guys, Alan and Jared. Just what you think about the medications that are sometimes used to help this. I've basically found that it doesn't work. On the course that we took, the doctors, everyone there who was teaching us, the physios, they were all suggesting that it's not very helpful.
Yeah, I would have to agree with Alex. Most of the patients that come in, they're already, if they've seen their doctor already, they're already on CIRC, but they're still coming in because they're still having issues with it. And like most of you guys, probably most of the cases that we do see with BPPV, it's like 1 or 2 sessions and it fixes it, and then they don't need the medication, right? So one is more natural way of just fixing the crystals or fixing the issue as opposed to being on medication. And yeah, majority of people that come in are already on CIRC and they're still coming in, so they're obviously still experiencing the symptoms.
Yeah. Well, guys, just from the knowledge that I've given you and using a little bit of common sense, you tell me if there's crystals in here, until they come up with a medication that makes it disappear, then it's obviously this needs to go back home. If you guys can remember that needs to go back here. There's no other way. Some people have just a little bit of crystals chronically, and they're like, they walk around, they always had a certain degree of dizziness with head movements. So some are acute where they're like debilitated, and some just have a little bit of crystals in there, and they can be fixed as well. But a lot of people are like, well, yeah, I have a little bit of dizziness day to day, but I can live with it. That's because your brain has recognized that that's in here and has found ways to cope with it. And so your brain adjusts, and now it like kind of turns down this nerve a little bit, so it's not firing as much, so that the eyes don't bounce around in the head. But no, medications for this I find to be ineffective. It can take the edge off for different other types of dizziness, but we're not going to talk about those today. We may expand on this topic towards the end of May, depending if we're back in the clinic or not, but we don't know yet. Because there's also like the neck after a car accident or a concussion that can cause dizziness. That's a little bit different. Having an ocular or eye problem can cause dizziness. There's a whole bunch of things.
And the nerve problem that you mentioned earlier, like if there's an issue with the nerve, of course.
Yeah. Like if you have an upper respiratory tract infection or inner ear infection, it goes and it congests around the nerve, and then the nerve is going to slowly start to shut down. So the presentation is almost the opposite of this stuff, where the crystals are making it hyper excitable. When you have an infection or an inflammation, it actually shuts down the nerve, and then you still get beating, but in the other direction.
Hey guys, I'm curious about this one question I saw come up a couple times, the half somersault maneuver. Do you know what that maneuver is?
I don't.
Nope. What's that?
I know a cool maneuver that you can do to fix this at home as well, but it's not, I don't know if it's definitely not that. Listen, I wouldn't give the half somersault exercise to your 91-year-old. You know what I mean? It doesn't sound like a good idea. Do you know what it is, Alex?
No, I don't. That's why I was asking. Somebody's asked a couple times. I think it was Anne Milocic.
And if you want to put your video on, you're more than welcome to either tell us or demonstrate. That'd be even more entertaining for everyone.
Have you guys seen clients on virtual care yet with BPPV?
I've had two.
I've had one, and so one of the techniques I give is the Brand Daroff technique, which is pretty good. And I've seen them for one session. They've been able to manage it on their own. And that was like 2-3 weeks ago, and I've been keeping up with them through emails, and they're fine. So there are things that we can do through virtual care right now. I know it kind of sucks that we're in the clinic because it's easier just to go in there and fix the issue and kind of address other issues that might be happening in your neck and other things. But
I mean, I could totally treat someone with BPV through this platform. What's tricky about it is that you almost got to assume it's posterior canal, because unless you can put yourself in this position and selfie your eyes for me, which would be like, and plus you feel like you're falling off the earth, that'd be a tricky one. So, but you can definitely coach through how to do like an Epley's maneuver or some of these maneuvers to try and treat yourself. Totally.
Yeah.
Anne is on. I don't know if we can hear you though. Yeah, your audio isn't working.
Try clicking next to the audio button, the little up arrow, and see if you can maybe modify through that.
Okay, can you hear me now?
Yeah,
we're good.
Okay, all right. The half somersault maneuver is some famous physician in the U.S. It's a woman. I found this when I was looking up Epley maneuver several years ago, and she does describe it using a model who looks like she's in her early 20s. So yes, I agree, probably a 91-year-old, unless it's Hazel McCallion, who's really, quite mobile and whatever. It wouldn't be appropriate, but I do find that it has worked for me, and like I say, it is easier for me to do and to follow. She has a really good video. It's less than 10 minutes and describes, the pathophysiology just the way you have, and gives the demonstration with this young lady. And I find I refer to that.
That's awesome. Well, listen,
yes.
I'm glad we did this webinar just on that fact that I can go and learn that. So I'll look it up later and we'll see if we can include it. If I think it works, totally, I'll look into it. Thanks for sharing that. That's awesome.
Definitely. Thank you.
Thanks, Aaron.
We got another one. It was what other maneuvers names beside Epley's? There's a whole bunch. There's Gufani's. What else we got?
Samant, Brand Daroff.
Yeah, there's a bunch, and then they're right, left, and then there's some that you sustain for 30 seconds, some that you hold for a minute or more if it's stuck to the cupula. It gets kind of complicated. Don't worry about how many maneuvers, unless you want to become a vestibular physiotherapist. Then send us an email after. We got about a minute left, so we're going to close this one for today. Guys, thanks for joining. Those questions were awesome, super interactive. Just know that if you guys know that if there's someone who's dizzy that needs help, there's a place to go that we can help you out. It's one of my favorite type of clientele. It's almost like everyone knows I'm already obsessed and I'm passionate about physio. That's almost like a sub passion within the profession that I really love. Concussion being another one, which we're going to be talking about on here in 2 weeks. Alex will be joining for that. This coming Wednesday at 11 a.m., our registered dietitian, Maria, is going to be joining us talking about some nutritional tricks to consider during COVID, to maybe not have to go to the grocery store as often, all those things, even though things are turning around. But she'll be talking about some nutritional facts that might interest you guys. Bring your questions, because there's going to be a big Q&A for any nutritional advice you might be looking for. Otherwise, guys, thanks for joining. I know we're going to be cut off. Have a great weekend, and special thanks to Alan and Alex for joining today.
Thanks, Pierre.
Thanks, guys.
Have a good weekend.
Bye, guys. Thanks for
having us. Stay safe.
Bye.
Good. You guys are good. Maria, you here? Maria was gonna test her video because she's on next Wednesday. But you guys are good. If Maria